Hello, good morning. It's currently 4:31 as you can see. I started just on time, 1 minute late. Uh, Yesterday was 17-hour marathon, so yesterday was a great day. I did sleep late comparatively, so I've slept really less yesterday night because I don't know, I was in the excitement. But now I have to really come home and sleep, otherwise I don't want to fall in. So now I want to work hard. I want to make sure I finish my CVS ka thing abhi only and do thoda maybe an art or something. Hello Aryan. Nice, you're the first one to join 4:30. I should schedule it. I'll schedule tomorrow ka also. So then I just have to come tomorrow and just join, just start it. Rojka, I'll just get it scheduled. Make a system where it's auto scheduled. I don't know if I can do that. Hello, hi Shanashi. Hi Aryan. So nice, you already have three people. Very nice. Hi Rajat, good morning. Good to see you all here. I slept less yesterday. I sleep when I come back home. That's the beauty of 4:30. Like you have to keep up the grind. No choice. And that forces you to sleep early. Otherwise you regret it. I'm scheduling tomorrow's also this like tags and all. Hello. Inflamed Ayush. I'm Aryan from Antakan. Okay. You can put your goal now what you want to do. Uh, I will say, let me think properly how do I want to do this. Okay, till till 7. Okay, fine. I'll do skill certification. Okay, fine. Till 7:30, I'll do skill certification extremely properly. CVS ka. I want to do well. Read like everything about it, all corollaries, and then I'll just get ready. Nothing much really. So today my whole thing is just to do CVS skill certification till 7:30. You can also add your goals. We can keep each other accountable. Uh, Method, okay, that BP basic principles. I'm scheduling a stream, and tomorrow morning becomes easy. Hmm. Tomorrow's day 15. Okay. Yeah, I should do this in your free time, not now. Now I'll keep for studying. Okay, I'll just finish it now. But I'll schedule and keep next day ka so subah I don't spend any time. Hello Sahil. Hello MS. I'm just gonna call you MX Blaze. Blakes. MS. Okay. Now we have six people, so nice. Okay, I'll just get something to eat and fresh. You all also please eat, drink, keep everything ready. A lot of people are saying I was on mute yesterday. So I think for 5 minutes I'll just talk. So then we both will get in the flow. Like even focus, and then you guys can also just after 2 3 minutes just get on track. So I'll just stay on, and then after that I'll go on mute. So then it won't disturb you guys. For the start, for just 5 10 minutes, I'll just speak. So it'll make sure we both are focused, and then we can really give our all in this 2 3 hours now. Be as productive as possible. Right. So observe the precordium for pulsations other than apex beat. Pulsation in the left third of fifth ventricle space point, and then you can understand also how I study. A lot of people ask me, like, what is your way of studying? How fast do you read? How fast do you do things? So recording the pulsation other than the apex beat in the left or third fifth intercostal space of the sternum points to right ventricular hypertrophy. So enlargement of right ventricle, left third fifth intercostal space, you will get pulsation, and a pulsation in the second left intercostal space may be due to a dilated pulmonary artery. So third and fifth is due to right pulmonary enlargement, right ventricular enlargement. Second intercostal space in the left side is due to artery, pulmonary artery dilated. So dilated pulmonary artery on the left side. Second left intercostal space may be due to dilated pulmonary artery, and second right intercostal space is due to aneurysm of aorta. So pulmonary area is also on the left side. So second left intercostal space is pulmonary artery dilation, and right second intercostal space is due to aneurysm of aorta. And third and fifth intercostal space, uh, if you have the palpitation of the left third and fifth, that means the right ventricle is enlarged, right? Moving on to pulsations around the precordium. So check for pulsation around the precordium. Look for suprasternal notch, epigastrium, and the neck. Suprasternal notch, epigastrium, neck. Suprasternal, epigastrium, and the neck. In the neck, the pulsations are of the carotid artery and the external jugular vein. So suprasternal notch, epigastrium, and the neck. And the neck pulsations are of carotid artery and the external jugular vein. So neck में pulsations are of carotid artery and external jugular vein. Yeah, mainly the external jugular vein, but we measure internal jugular vein. Uh, and the cause of epigastric pulsations are, why will there be epigastric pulsations? One, hypertrophied right ventricle, correct? Pulsation. So either the right ventricle is hypertrophied, abdominal aorta pulsations in thin individuals, like very thin people may you can feel it, and aneurysm of the abdominal aorta. So right ventricular hypertrophy, aortic aneurysms, uh, like abdominal aorta. So abdominal aorta aneurysm and abdominal aorta pulsations can be felt in thin individuals. This will lead to epigastric pulsation. And remember the liver also. Pulsatile expansion swelling of the liver. Pulsatile expansion swelling of the liver. And what I usually do is I haven't done it now, but I usually time every page. So this is one system you can use. It really boosted my productivity. So I'll show you what I do. Mm. So basically, every time I start a new page, I just start a timer, and then I keep myself accountable. This page I took this much time, like say 5 minutes. So then next time I'll say, okay, let's or say I took 10 minutes. I improve it. Next time I'll take 9 minutes 30 seconds. Keep trying to reduce it. So you have a self accountability way also, right? This really works for me. Mm, Now, I said pulsatile swelling of the liver. Pulsatile epigastric pulsatile swelling of the liver. Now, inspection of neck veins. The neck veins communicate directly with the right atrium and provide information about mean hydrostatic pressure and pressure changes in the right atrium during the cardiac cycle. So the neck veins are communicating with the right atrium, and they're telling us about the mean hydrostatic pressure and pressure changes in the right atrium. For inspecting the neck veins, my mouth is too dry. I don't drink water. Usually, when we say things loudly, it always gets reinforced better. So when you're studying, try studying loudly if you can, because I feel that's more effective than we get lost sometimes if you're not talking loudly. Uh, and what I do is like when I was not live streaming, I would take a camera and I would place it in front, and I would make like I would make a time lapse. So then I knew that when I wanted to see, so when I knew there's a camera in front of me, I would not do time pass. So like you won't get up from your table unless you won't take your phone and all, and use your phone only to record. So you can't even use your phone to do time pass. So always when you're studying, just sit and record a time lapse of yourself. Keep record a video of yourself. So you know you want to look good in the video, so you'll study, right? Inspection of neck veins. The neck veins communicate directly with the right atrium and provide information during the mean hydrostatic pressure and pressure in the right atrium. For inspecting the neck veins, the subject should be reclining at 45 degrees with his back rested and supported against a backrest. He should be reclining at 45 degrees uh, with his back supported against a backrest. The neck is also supported so that the neck muscles are relaxed. Neck muscles are relaxed. The internal jugular vein, usually the right internal jugular vein, is selected for the examination since it communicates directly with the right atrium and affects the pressure changes in the chamber. Right internal jugular vein directly right atrium से communicate करेगा. Uh, the external jugular vein is not always reliable for this purpose and should not be utilized. Why? Because it can have anatomical variations, it has valves, and it is narrow. So, external jugular vein is narrow, it has valves, and it has anatomical variations and is prone to undergo kinking. So it can go undergo kinking. That's why we don't use it. Kinking also is another factor to consider. Okay, kinking. I have to check what that is. Twist. ठीक. It's like twisting and kinking of the arteries due to atherosclerosis. Okay, and is distinguished from coiling. Oh, okay. It's due to atherosclerosis. So it's more prone to kinking atherosclerosis. ठीक है. Now coming to palpitation. So this was inspection. Inspection is what you see. Palpitation is when you actually feel. Confirm the facts determined by inspection. So palpation में क्या क्या है? Apex beat. Apex beat में क्या क्या है? Apex beat में you check the position and the character. Character has rate, rhythm, and force. RRF. Right. Now coming to apex beat is first felt with the flat of the hand. So you first keep the flat of your hand over the area, then you keep the lateral tip, and then you take the finger exactly and point it where you would expect the apex pulse to be felt. Apex beat. And then with the fingertip precise location, force, and action on palpation of normal apex beat is felt in the left fifth intercostal space, 3.5 inches from the mid-sternal line and half inches medial to the mid-clavicular line. Half inches medial to the mid-clavicular line and 3.5 inches lateral to the mid-sternal line or the sternum, basically the sternum. Its force of amplitude is moderate, correct, with brief duration, and its extent is essentially less than 1 millimeter in 1 inch in diameter. Okay. Apex beat is displaced in scoliosis, pleural effusion, pulmonary fibrosis. Apex beat is displaced in pulmonary fibrosis, pleural effusion, scoliosis, and in cardiac enlargement. Cardiac enlargement makes sense. Pulmonary edema, pleural effusion. Then you have in scoliosis because there's a lateral shift of the full vertebral column. Scoliosis, pleural effusion, pulmonary fibrosis, pleural effusion, pulmonary fibrosis, cardiac enlargement. ठीक है. If the apex beat is not felt in the recumbent position, it may become palpable by turning the subject to the left or make him sit up and lean forward. So, if you're not feeling it, then you make your subject turn to left like this, or you make him sit up and lean forward. Either you make him go left or sit up and lean forward. In the left lateral position, the apex beat may shift up to anterior axillary line. So left lateral position. In the left lateral position, the apex beat may shift up to the anterior axillary line. In the left lateral position, apex beat may shift up to the So in the left lateral position, it shift to the anterior axillary line. Correct. Despite these maneuvers, the apex may not be palpable if obscured by a thick chest wall. So you won't feel an apex if it lies behind the rib or if it's obscured by a thick chest wall, maybe like in obesity. So in obesity, or if it's retrosternally placed. So retrosternally placed or obesity, then you won't see it. Now, And the last thing to say is dextrocardia, not in the start. Failure to palpate the apex beat on the left side should want to feel for it on the right side. This may be detection of dextrocardia. Now, character. So, this is all about the position of the apex beat. Normally, the apex beat raises the palpating finger without an undue thrust. It raises the palpating finger without an undue thrust. A forceful thrust. Dhak, 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 dhak. When will a forceful thrust be felt? In cardiac hypertrophy? The heart is excessively pumping, excessive heart muscle, so more cardiac muscle only, so more apex beat will be felt. Logically, it will be more thrustful when we have cardiac hypertrophy. Tapping apex beat is felt in mitral stenosis. So cardiac hypertrophy may you have apex beat rising. Cardiac hypertrophy, apex beat, forceful thrust is felt in cardiac apex. You have a tapping apex felt in mitral stenosis. So cardiac hypertrophy, forceful thrust, mitral stenosis. Then you have a tapping apex beat. Now force, when will the force be increased? In nervous people after exercise and hypothyroidism. So when you're nervous or after exercise or after hyperthyroidism, the force will be increased. Now feeble diffuse impulse. Feeble diffuse impulse with the position shifted downwards towards the axilla is felt in congestive cardiac failure. So when the position is shifted towards the axilla, that is felt in congestive cardiac failure. It confirms the rate and rhythm of the you yourself have to confirm the rate and rhythm of apex beat. So feeble diffuse impulse with the position shifted towards the axilla. Feeble diffuse impulse position shifted towards the axilla is felt in congestive cardiac failure. I don't even know much how exactly congestive cardiac failure causes what all. I haven't studied much about it, but okay. Position shifted towards I have to go faster. I have to go faster. Shifted towards the axilla. It's a feeble diffuse impulse. Feeble diffuse apex beat is felt in congestive cardiac failure, where it's moved towards the axilla, and you confirm the rate and rhythm. Now palpate the precordium for pulsations other than the apex beat. Hmm. So see, I took 9 minutes, right? Which is too much. So now next page I'm gonna do within 7 minutes. Let's go. Yeah, we've started. Let's go. 7 minutes. Palpate for epigastric pulsations. You check the precordium. You check the epigastrium. Now heart sounds. Palpate the precordium for heart sounds. When you're palpating the precordium for heart sounds in normal subjects, the heart sounds are not palpable. However, the first heart sound may be palpable in some individuals with thin chest wall. So first can be palpable with thin chest wall. Accepting these situations, palpable heart sounds increase the increased intensity. Now coming to thrills. Thrills are palpable vibrations resembling the sensation produced during the rustling of a purring of a cat. Okay. Thrills is purring of a cat. Thrills is purring of a cat. They are best felt with the flat of the fingers. The flat of the fingers normally. No thrills are palpable. Yes, no thrills are palpable. They are felt with the flat of the fingers and they are similar to the cat purring. And they are audible by stethoscope. And the thrills which are audible by stethoscope are called murmurs. Okay, I should eat a banana for sure. Okay, well, I still continue reading. Still continue reading. Tubular venous pressure. I've developed. I can read and eat also. Actually, I'm enjoying neat as to do that. Because like I'm most productive when I'm saying something out loud. Determinant, that's kind of harmful, dangerous, but still. Determinant jugular venous pressure indicates right atrial pressure. Jugular venous pressure indicates right atrial pressure. It denotes the mean pressure in the internal jugular vein during cardiac cycle. To determine it, raise the subject's head at an angle of 45 degree and measure the height of the distended jugular vein above the sternal angle. Height of distended jugular vein above the sternal angle. And since the sternal angle is at a fixed distance of 5 centimeters from the center of the right atrium, Okay, so you measure the height of the distended jugular vein above the sternal angle, right? Height of the distended jugular vein above sternal angle. Sternal angle के ऊपर distended jugular vein. So the lateral sternal angle is at a fixed distance of 5 centimeter from the center of the right atrium in any position of the subject. The sternal angle is at a fixed distance of 5 centimeters from any position of the subject. So center of right atrium say, okay, center of right atrium say it is 5 centimeters. Okay, this is distance sternal angle. ठीक है. Yeah, fine. 5. हाँ बोल सकते. Measure. Okay, 5 centimeters in any position. It serves as a convenient reference point for expressing jugular venous pressure. So check for jugular venous distension at a fixed distance above the sternal angle, and lateral to the sternal angle 5 centimeters. You have the right aorta, right atrium. The sternal angle is a fixed distance of 5 centimeters from the center of the. It's other convenient reference. Okay. Normally, the extent of filling is 1/3 from the clavicle to the angle of mandible. The extent of filling is 1/3 from clavicle to the extent of the mandible. 1/3 from the clavicle to the. I'll have to watch a video on this. I'm not confident with JVP, so I'll definitely watch a video. I'll put that after I'm done reading. I'll watch a video on JVP for sure. So make sure always concepts are clear and don't leave anything. If you feel you're not confident, just watch a video. There's everything is available nowadays. So, okay, this is done. Fast. We're already at 4 minutes. Come on. Okay, the normal pressure is of 2 to 4 centimeters of water. Normal pressure is 2 to 4 centimeters of water in the jugular vein. Okay, 2 to 4 centimeters of water. 2 to 4. The upper limit of normal jugular vein is 2.5 centimeter. Jugular venous pressure is 2.5 centimeters above the sternal angle, with the subject reclining at an angle of 45 degrees. And this pressure, the jugular venous distension extends up to a point just below the clavicle. So reclining at 45 degrees, and the pressure at this pressure, the jugular vein distension. So at this pressure, the jugular vein distension extends up to a point just below the clavicle, and hence it is not visible. So it extends just below the clavicle and it is not visible. Okay. So 2.5 centimeters above the sternal angle at angle of 45 degrees just below the clavicle, hence it is not visible. However, the jugular venous pulsations extend slightly beyond this level and they are just visible at the root of the neck. Jugular venous pulsations extend slightly beyond this level. So jugular venous the distension will extend up to a point just below the clavicle, hence not visible, but the venous pressure will extend beyond the level and they're visible at the root of the neck. Okay. The pulsations are visible at the root of the neck. When the jugular venous pressure is increased, both the venous distensions and the pulsations are visible in the neck much above the clavicle. Okay. And when the venous pressure is only increased, both pulsation as well as the distension of the veins will be visible above the clavicle in both the cases. They may be visible even in the upright position. Fine. So I think upright position also, the veins can be visible even in the upright position. Okay. When the pressure is decreased, jugular venous pulsations are not visible in the neck at an angle of 45 or even less. So अगर pressure कम हुआ तो pulsation you won't feel in neck also even at 45 or less. The subject's inclination of 45 degree of angle is critical and is utilized for clinical purposes. 45 degree angle is clinical and is used for clinical purposes. Effect of gravity on jugular venous pressure is the basis for this measurement. Effect of gravity is the basis of this measurement. Gravity, effect of gravity. Okay. Now jugular venous pressure. Jugular pressure refers to a term of oscillation seen in the jugular veins during a cardiac cycle. Oscillation in the jugular vein. The instrumental record of a normal pulse shows three waves: A, C, V wave. One of these A and C waves are normally visible in the neck, and V is too small to be clinically recognized. So A wave and C wave are normally visible in the neck, and the V wave is too small to be clinically recognized. So A wave and C wave is seen, but A wave, C wave seen, V wave is not clinically recognized. A and C are seen in the neck. V is too small to be recognized clinically. Hmm. A and C wave, A and C wave, and V is too small to be recognized. Okay, okay, fast, fast, fast. Come on. The A and V wave are identified by palpating the carotid pulse. So A and C wave can be felt in the jugular venous pressure, and the V, like A and C, they are visible in the neck, and the V wave is not visible. Okay, it's visible in the neck, A and C, but V is not visible. V is too small to be clinically recognized. Okay, but the A and V wave are identified by palpating carotid pulse. So for seeing the for seeing them, you can't see it. Visible is A and C, not V. But A and V are identified by palpating the carotid pulse. So A and V are for carotid pulse, identifying the carotid pulse. A and V wave. A and V wave will help monitor the palpate the carotid pulse. Carotid pulse. A and V wave. A wave precedes, whereas V wave follows the cardiac pulse. Carotid pulse. So A wave will be before the carotid pulse. V wave will be after the carotid pulse. Because A will be the contraction, and V is essentially the vena cava filling, I guess, back. Yeah. Correct. Jugular venous pulse informs us about right atrial pressure changes during cardiac cycle. A prominent A wave indicates high atrial pressure. Because it's A wave is atrial contraction, so high peak will indicate high atrial pressure when the chamber contracts against resistance. So tricuspid stenosis. So there's stenosis of the tricuspid valves, they not function properly. That's why there'll be a high pressure created because it can't go into the ventricles, right? So the A wave will be nice, prominent. That makes sense because of right tricuspid valve stenosis. That will cause right atrial pressure to be high. Fine. In atrial fibrillation, there is no active atrial contraction. I mean, there is continuous contraction, but it's not like proper, it's not regular. So there is no active atrial contraction, and A wave may be absent. So A wave is absent in atrial fibrillation, and A wave is high during right basically tricuspid stenosis. Okay, next page. See, this we took 10.5 minutes. So again, not up to the mark. So okay, let's not make big. Next time I'll try to finish it within 9 minutes. This was a bit of a tougher page. So now I'll finish with every time I'll keep accountable so that you know we can keep reducing every time. So now we'll try to finish it within 9 minutes. That's most important to keep a track of our time. Every second matters, every minute matters. Right? Now coming to percussion. To map out the area of cardiac dullness by which the size of the heart can be determined, right? You're mapping out the basically percussion is very time pass. You're just finding the borders of the heart. Mm. The left border is determined as follows. Look at the apex beat. Start percussing from the mid axillary line from the lateral to the medial in the fifth axillary intercostal space till you get a dull note and mark the point. Now repeat the process. So fifth may you do it. Repeat the process in the fifth, fourth, third, second. Mark the points and join the point. By joining all the points of dullness, you will get the left border of the heart. Now, left border of the heart is formed by the left ventricle. Percussion of right border is determined by starting the percussion from right second intercostal space downwards in the mid clavicular line till a dull note is heard due to the liver. Okay, you go downwards along the mid clavicular line till you hear a dull note in the sixth intercostal space. Oh, so first you go like this, and then you go one intercostal space above. Start percussing from lateral to medial till a dull note is elicited. I haven't practiced percussion. Hmm. Like basically, you're supposed to take put this and then based on what sound you hear, you have to either say it's a dull note, resonant note. ठीक है. Mm, okay, fast. Suppose of initially defining the upper limit of liver dullness is to avoid mistaking the liver dullness for cardiac dullness. So you're differentiating it. That's why you're taking the liver first. That can be viva question. And you start one into above lateral. ठीक है. Repeat the process in the fifth, fourth, and third. So left border के लिए you did fifth, fourth, third, second. Right border you're doing fifth, fourth, and third. Like fifth, fourth, and third intercostal space. ठीक है. Normally, the right border of the heart lies under the sternum. Oh, right border of the heart lies under the sternum. Right border of the heart is formed as the right atrium. Right border of the heart is retrosternum. Now, cardiac dullness. Normally, the lowest and the outermost point of cardiac dullness is located in the fifth left intercostal space. Lowest and outermost point, 3.5 inches from the mid-sternal line and half inches inside the mid-clavicular. And the corresponding question is apex beat. So upper limit of cardiac dullness is defined by percussing just lateral to the left sternal margin from the infraclavicular space downward. So your upper limit of the cardiac dullness is being defined by percussing just lateral to the left sternal margin. This is the left sternal margin, and you're percussing just lateral to it. Okay. For the upper limit. Okay. From the infraclavicular space downward. Oh, so if you want the left upper limit of the heart, you're going along the mid clavicular line from the sternum, and then you keep going laterally, medial to lateral. Okay. There's something that I missed out in my first reading. That's not good. This is my second reading. Hmm. Upper limit of cardiac dullness is defined by focusing this line. Okay. Normally, the upper limit of cardiac dullness is reached in the third left intercostal space. Oh, so third left intercostal space, you're getting cardiac dullness. Third left intercostal space, you're getting cardiac dullness. Cardiac dullness in third left intercostal space. Okay. Now, importance of the cardiac percussion. Detection of cardiac dullness beyond the normal limit points to either enlargement of the heart or the shift of the heart due to pulling of mediastinum in lung diseases. So, cardiac percussion, you need detection of the cardiac dullness beyond the normal limit. There's a cardiac dullness, and beyond the normal limit, if you get the cardiac dullness, it will point to enlargement of heart, shift of the heart due to pulling of the mediastinum in lung diseases. So either the enlargement of the heart or the shift of mediastinal diseases, pulling off the mediastinum itself in the lung diseases. So you're pulling the mediastinum in the lung diseases, or your heart is only increased in size, enlargement. Eat. Now auscultation. It gives information concerning the function of heart valves and the state of the myocardium and the pericardium. Mm. Oh, wait. Where the apex beat is not visible, the position can be reduced by percussing along the left border of the heart. Percussing on the left border of the heart. Now, auscultation. Auscultation, it gives information concerning the function of heart valves and the state of the myocardium and pericardium. So, function of the heart valves and the state of the myocardium and the pericardium, myocardium and pericardium. Correct. State of the heart valves and the myocardium and pericardium basically. There are four areas of auscultation. Mitral area is basically the apex of the heart. Mitral area, tricuspid area is in the fourth left intercostal space, just lateral to the sternal border. Aortic area is in the right second intercostal space, 2 centimeters lateral to the sternal border. Pulmonary area is in the left second intercostal space, 2 centimeters lateral to the sternal border. Now see, I finished within 7 minutes. So that's an improvement, right? See, live example of how you can improve. So now I'll keep trying to maintain this. Right. So now it's 7. Before that it took 9 minutes. Before that it took 10.5 minutes. Now I'll try to maintain 7 minutes. This is how you save time, become faster, become more productive. Again, we will aim for 7 minutes. Come on, let's go. Feel the carotid artery pulsations while auscultating the heart sound. You're feeling carotid artery pulsations while auscultating for heart sounds. Carotid artery. So carotid artery has to be felt. Carotid artery has to be felt. You need to feel the apex beat and the carotid artery. The heart sounds are heard during auscultation. Carotid artery may also you have to go and check for heart sound. Okay. The heart sounds are heard during auscultation. It is to be noted that these areas do not correspond to the anatomical position of the valves of the heart. Like also because the sound produced by these valves are the best heard in these areas. Okay, I'll talk less with less force so that I conserve my energy. The sound produced by these valves are best heard in these areas. Best heard in these areas. Both the first and second sounds are heard in all four areas. However, the first sound is heard better in the mitral and tricuspid area, and the second sound is better heard at the aortic and pulmonary areas. The first heart sound is soft, low pitched, and prolonged, resembling utterance of the word lub. So it's prolonged. So lub, L-U-B-B, lub. So it's soft, prolonged, and low pitched. Soft, prolonged, low pitched. So first heart sound is low pitched. So because it's first, so we'll remember low. So soft, low, and prolonged. I say calm. Soft, low pitched, prolonged. The utterance of the word lub. The second heart sound is short. Okay, second heart sound is not prolonged, it's ulta. So it's short, it's sharper, and it's high pitched. So first heart sound is slow. It is soft, low pitched. First heart sound is soft, low pitched, and prolonged. Second heart sound is slow, it's sharp. It's shorter, not slow. It's less time, no? So it's shorter. It is sharp and it is high pitched. Correct. Makes sense. Designing the word dup. Lub, dup. Lub, prolonged, dup. Lub, dup. The third heart sound may be heard in some young adults and children. Third heart sound is caused by the vibrations produced during the first rapid filling of the ventricles. I don't know why I keep forgetting this. Okay, now I'm going to remember it so properly I'll never forget it. The third heart sound is heard when you have first rapid filling phase of ventricles. First, the vibrations that are produced in the first rapid filling phase of the ventricles. First rapid filling phase of the ventricles. First rapid filling phase. So the first rapid filling phase of the ventricles is the third heart sound. The vibrations. Rapid filling of the ventricles. Done. I won't forget this now. Rapid filling of ventricles. Okay. The first rapid filling phase of the ventricles, the vibrations produced. The fourth heart sound is normally caused by the last rapid filling phase of the ventricle. So first rapid filling phase of the ventricles is due to causes third heart sound. Last rapid filling phase of the ventricles causes the fourth heart sound due to atrial systole, and it is not heard normally. Last rapid filling phase of the ventricles due to atrial systole. ठीक. The heart sound can be clinically timed with the carotid pulse of the apex beat. The first heart sound coincides with the carotid pulse. The carotid pulse is best felt behind the angle of the jaw. Exactly, I want to check the angle of the jaw. What that means. Okay. Okay. So this, correct. This is exactly the angle of the jaw, and it's felt just below the angle of the jaw. Hmm. Okay, I'm getting a decent. Mm, the first ultrasound corner, the carotid pulse is best felt behind the angle of the jaw. Since the apex beat is not always palpable, it is better to be familiar with the timing of the heart sound with the carotid pulse. The heart sound which occurs with the carotid pulse is the first heart sound. The heart sound that follows the carotid pulse is the second heart sound. This helps to distinguish first heart sound from the second heart sound. In some young individuals, the second heart sound is normally split during inspiration. This is an important point. So if you're a young individuals, second heart sound is split during inspiration. This is due to the separation of aortic and pulmonary components of the sound. Splitting of the sound is due to splitting of aortic A2 and P2 components of the sound. Splitting of the second heart sound A2 and P2 components of the sound. A2 and P2 components of the sound. And the second sound is single. The split can be produced by asking the subject to take deep inspiration. Okay, so regarding a single second sound, deep inspiration. Okay. During deep inspiration, the venous return and right ventricular filling increases. Deeper inspiration बढ़ रहा है, right ventricular filling बढ़ रहा है, and its ejection time is prolonged. The occurrence of P2 is therefore delayed. P2 is pulmonary. Right से किधर जाएगा? Right से जाएगा pulmonary में. Or because pulmonary में it's taking more time to fill, correct? That P2 will get delayed, but A2 will go faster because A2 is getting from left ventricle. Left ventricle is getting from pulmonary veins. Pulmonary veins is to aram se is giving. But increased venous and in deep inspiration, you're basically increasing the venous return. Increasing the venous return means you're increasing the right ventricular filling. Means the right side ka delay hoga because more is coming. So it takes more time to push everything out. So the A2 will be heard before the P2. At the same time, the left ventricular filling is decreased and its ejection time is shortened. A2 occurs early. The separation of A2 and B2 gives rise to splitting of second heart sound. So अगर naturally नहीं हो रहा है young individual में जैसे होता है, then you ask him to take deep inspo. Except for splitting of the second sound in the pulmonary area. Okay, you feel it in the pulmonary area, which is left side, left second intercostal space. Any splitting of the heart sound is abnormal. Also sounds like pericardial rub. Let's check. What is pericardial rub? It is heard over the left sternal border, often louder at inspiration, seen in acute pericarditis. So you're seeing it in acute pericarditis and over the left sternal border. So basically, uh, except for splitting of second sound in pulmonary area, splitting of heart sound is abnormal. Also sounds like pericardial rub and murmurs are abnormal auscultative findings. Pericardial rub and murmurs. Murmur is like basically apna auscultation of thrills, like we read. Other abnormal auscultative findings, murmurs and pericardial. Okay, fast. Come on, go faster. Okay, this one took a bit of time, but at least I have accountability. It took 8 minutes. I could have done faster though. No worries. We'll keep the pace. Now coming to Observations. Name Sanmasha, age 19, male, dyspnea, chest pain, palpitations absent. So symptoms में dyspnea no, chest pain no, palpitation no. So chest pain नहीं है, dyspnea नहीं है, palpitation नहीं है. General build, average nourishment, average pallor no, pulse 72, pressure 128, clubbing not seen, cyanosis not seen, edema absent, and edema absent. Neck veins is visible. So neck veins are visible because I was thin individual. So neck veins were visible. Not all. I mean, they should be, but mine were more prominently visible. And systemic examination of the heart, inspection of. Okay, this is most important. This was general examination, not so important. But you'll check build, nourishment, pallor, pulse, pressure, clubbing, cyanosis, and edema and neck veins. Okay. No one will ask. Wow, today was not. Genuinely, I feel I've done it much faster. Okay, let's go. No talking. Systemic examination heart. Coming to systemic examination, one is inspection. Inspection, may you have three things. What all are you inspecting? You're inspecting the chest wall. You're inspecting the precordium. You're inspecting apex beat. So you when you're inspecting, you're just looking chest wall, precordium, apex beat, apex impulse, not apex beat, cardiac impulse. उसका position and character, you handle force and rate. So position and character, and of course the pulsations. Like कौन से pulsations were inspectable, either suprasternal, epigastric, or carotid. Are they just visible? No. Now, so inspection में chest wall is symmetrical. Chest wall symmetrical. Precordium is neither bulging nor retracted, normal. So it's neither. So I'll say it like that. I inspected the cardiovascular system or the chest wall of my patient. This name, age this, and after taking due consent, and I found from my inspectory findings that the chest wall was symmetrical, the precordium was neither bulging nor retracted, the apex beat was seen from when standing on the right side near the legs of the patient. The thin up and down movements of the chest wall were able to be visualized. The position of the apex beat was near the and I don't think you can give exact dimensions. That will only come by palpation. I'll have to ask what exactly the position you have to say. The character, but I guess you can just say near the fifth intercostal space, but we can't say like that by just saying. Okay. The rate was 72 beats per minute. Rhythm was regular. Okay. That is a character. Rate was 76 or 72 beats per minute, and the rhythm was regular. Okay. Pulsation in suprasternal, epigastric, and pulsation in suprasternal, epigastric, and carotid are not seen. Neck veins are not distended. Neck veins are not distended. Now, palpation. So this was inspection. Inspection is time pass. You're seeing chest wall, you're seeing precordium, you're seeing apex beat, you're seeing pulsations. That's it. And the neck veins, neck में veins and the palpations, right? Next, we are seeing come on fast. Okay, palpation, apex beat and jugular venous pressure. Apex beat and jugular venous pressure. Apex beat may you check the position. This so you can say half. I know this now. Half centimeters medial to the mid clavicular line. 3.5 centimeters inches. Centimeters will be 1.2 centimeters medial to the mid clavicular line, or half inches medial to the mid clavicular line, or 3.5 inches lateral to the mid sternal line or the sternum. That is the position. Character, rate, rhythm, force. Rate we know 72. Rhythm was regular. Force was adequate, moderate. I think moderate they like. Moderate, adequate. Adequate. Force is adequate. Force is adequate. The jugular venous pressure was 7 centimeters of extra. Usually it's 2 to 4, isn't it? 7? That's 7. 2 to. Okay. Damn. GGP देखना है, should have to still see the video. ठीक है, it's okay. Percussion Imagine this time pass. Cardiac borders, you start from the left. So in the fifth intercostal space, it is 10 centimeters from the mid axillary line. Okay, you have to measure it also. Oh, I should take a scale today. I should wear a watch also. हाँ एक्चुअली पल्स नहीं लेने. हाँ एक्चुअली एपेक्स बीट के लिए आई शुड पैक अ वॉच. यस. यस अपना सादा एग्जाम का वॉच. I've been wearing since my ICSE 10th standard. This watch has been with me for so long. Like ICSE guy has to go for my. No, I don't think. I think we were allowed in ICSE. Yeah, I remember wearing this. And okay, jugular vein specialist and okay. Percussion will be 10 centimeters from the mid axillary line in the fifth intercostal space, 13 centimeters in the 10 centimeters in the fifth intercostal space, 13 centimeters from. Let's measure how much is 10 exactly in the fifth from here. Okay, so if I measure from mid axillary, comes to around here in the fifth intercostal. Damn. So this, then 13 centimeters from the mid axillary. Oh, and 16 centimeters in the third. So 5, 4, 3, 5, 4, 3, 10, 13, 16. Basically, ऐसे जा रहा है वो. It's going from lateral to medial. Lateral to medial. 5, 4, 3, 10, 13, 16. I won't forget. 5. No, don't forget this long term. 5, 4, 3, 10, 13, 15. 5, 4, 3, 10, 13, 16. 16, not 15, 16. ठीक है चले इतना. No one will ask. Right border is retrosternal, correct. Oscillation mitral valve. First and second sounds are heard in both, but the first sound is okay. First sound is better heard in. The first sound is better heard in the mitral and tricuspid area. Second sound is better heard in the aortic and pulmonary area. Now, okay, done. That page is done. We finished in 8 minutes when I went to get my watch also. Not bad. Good, good. Next page, 7 minutes. Let's go. We can do it. Write a question and answer. Write your findings of the clinical examination of CVS and the fellow student. And CVS is within the normal limit. Okay, that's what we have to say at the end. The CVS of the patient is in the normal limit. CVS is in the normal limit. Okay. What is the importance of knowing venous pressure? Basically, the right side of the heart ka health. Estimation of venous pressure is important to know whether the central venous pressure is raised or not. When the heart fails to work, the blood accumulates on the right side of the heart and congestion of the veins is seen. So, by knowing the venous pressure, one gets an idea whether the patient has got right-sided heart failure or not. Right-sided heart failure or not. Ouch, my specs on. Okay, mention the factors causing physiological variations in venous pressure. What all can affect venous pressure? Let's think. Gravity will oppose venous movement. Like the position of the vein, venous pressure, where the vein is located, gravity, muscle pump, correct? Valves. So, the gravity, position of the veins, valves present, gravity, position of the veins, valves, muscle pump pushing it upward, and the thoracic and intra-abdominal pressure will cause a delta P pressure difference. It will cause a Q is delta P by our flow from the veins to the right atrium, right? So we have right atrium ka intra-abdominal and thoracic and intra-abdominal pressure. So firstly, the most important factor which will determine venous pressure is the position of the vein. Second is the valves. Third is the position of the veins, the valves, the gravity, position of the vein, valves, intra-abdominal and thoracic pressure, and the muscular pump. Done. How will demonstrate the presence of valves and new reduction flow in the veins? How will you demonstrate presence of valves and the unidirectional flow in the vein. Visible vein is emptied and pressed. You take a visible vein, you empty it and press it at two ends. Okay. So you're pressing it at two ends. Now you're releasing the proximal part. Okay. The vein will not fill due to presence of valves. Oh. So you are holding two ends of the vein. You're releasing the proximal part from pressure, and the vein will not fill due to presence of valves. Crazy. That's crazy. The vein will not fill due to presence of valves, right? So that'll stop the flow. Nice. I never realized when I read this, but I didn't think on what it meant. Now press the proximal part again, release from the distal end. Release from the distal end, and the vein fills from the periphery, indicating the direction of blood flow from distal to the proximal part. So you are holding at the proximal part, you are releasing the proximal part. The vein will not fill only due to presence of valves. Now you're pressing the proximal part again. Now you're releasing the distal end. So you take both proximal distal, you leave proximal. Now you press proximal again, leave distal. Okay. The vein will fill from the periphery, correct, indicating blood direction from flow from distal to proximal. Okay. When you're pressing periphery, it comes back. When you're not pressing, so the blood will not flow when you're releasing because of the presence of valves. So that indicates the presence of valves. Now I'm pressing it back, removing this. The blood will flow towards the proximal part, indicating the direction from the distal to the proximal. Interesting. Describe the characters of first and second heart sound. The first heart sound is best heard in the mitral and the tricuspid areas and is due to the closure of the atrioventricular valve. It is dull, prolonged, and low pitched. The second heart sound is best heard in the pulmonary and aortic area and is due to closure of semilunar valves. Second heart sound is best heard in the pulmonary and aortic area. Closure of semilunar valves. Second heart sound is due to closure of semilunar valves. Okay. Correct, of course. It is a sharp, short, and high pitched. Sharp, short, high pitched. Sharp, short, high pitched. It is sharp, short, and high pitched. Sharp, high pitched, and short. Okay, fast. The first heart sound is mimicked by lub, and the second heart sound is dub. Done. Nice. So it was 6 minutes. That is good. Good pace. Yeah. 6 minutes, 17 seconds. Let's go. So there's always scope for improvement. Keep timing yourself. Okay. Next page. What I do usually now, whenever I read something, I tick the page upper, like on the, say now I finished this page, I've ticked, give a small tick in the textbooks. Yes, speed is increasing. On the left side, I say, see this tick there. So every time I read that page, I tick it again. So maybe after like 5 revisions, I'll know how many times I've revised that topic. Every page I know, because often we take a topic, we read the first 5 pages and then the rest 10 pages are never read. Always we come with Josh. First page, Amisha, they're always read. The last pages are always blank. So keep ticking every single page, and the number of times you've ticked will tell you how well you know that topic and how many times you've revised it. So my bio NCRT by the end, like my 12th NCRT was tick 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 tick, tick. It was like a zillion ticks because I read that many times, right? So do the page ticks. Even I haven't been doing it. Honestly, I'm saying this. A lot of systems which I used to follow in NEET, I have also slacked. So by telling you all, even I'll start doing things. That is also good. It's a win-win, of course. Mm. I'll also restart this ticking thing. But now though you can't revise. There's no revision scope. It's just how many times, how much portion you can cover. Like 70%, 80% भी किया तो बहुत है. अभी ticking का सवाल ही आता नहीं वैसे. Yeah. Everything has to be read like this. Even chem. What are the third and chem NCERT has to be read line to line. What are third and fourth heart sounds? How are they recorded? Is it possible to hear them during routine auscultation? The third heart sound is produced due to vibration of the ventricular wall. We saw that during the first rapid filling phase. Now I will not forget. First rapid filling phase is the third of the ventricles, and the last rapid filling phase of the ventricles, the vibration, that is the fourth heart sound, and usually produced by atrial systole and is not heard normally. And the third heart sound and the AV valve cusps. So it is produced due to vibration of ventricular wall and the atrioventricular valve cusps by the inrush of blood during the first rapid filling phase. So both the walls are also producing it and the cusps are producing it. And first rapid filling phase of diastole. First rapid filling phase of diastole. During inrush of blood during the first rapid filling phase of diastole. The fourth heart sound occurs shortly before the first heart sound. Uh, I have. The fourth heart sound occurs shortly before the first heart sound. Okay, it occurs shortly before the first heart because after atrial systole now. Correct. And then the first sound will be heard because of the closure of the tricuspid and bicuspid. Okay. So fourth is heard shortly before first. It is caused due to atrial systole in the last rapid filling phase. These heart sounds are not heard during routine auscultation, but they can be recorded by. They're not heard during routine auscultation, but can be recorded by phonocardiography. Phonocardiography. Why is it preferable to hear the heart sounds in the four areas instead of direct auscultation of the valves? As the four valves are situated beneath the sternum, the conduction of the heart sound to the intercostal space, conduction to IC space is much better than conduction through the sternum. Hence, these sounds are heard with maximum loudness and clarity in the four areas mentioned above. What is sternal angle and importance? Sternal angle is the angle between the manubrium and sternum, manubria sterni and the body. Manubrium sterni and the body of the sternum. Between the manubrium sternum and the body of the sternum called as the Ludwig's angle. Manubrium sternum is the angle between the manubria sterni and the body of the sternum called as the Ludwig's angle. So manubria sterni and the body, which is called as Ludwig's angle, it is used as a landmark to count the intercostal space. The second costal cartilage is attached to the sternal angle, and the space just below it is called the second intercostal space. Now give the clinical definition of the cardiac impulse and apex beat. Cardiac impulse in the CPS examination is the area over which the impact due to cardiac systole is seen. It is a self-propagatory. Cardiac impulse is a self-propagatory electrochemical change traveling along the cell membrane of the conducting tissue and the muscle fibers during its excitation. So, uh, okay, cardiac impulse क्या है? It is a self-propagatory. Cardiac impulse is a self-propagatory electro, मतलब electro, electro this coefficient ये भी है gradient, electro gradient भी है. Electrochemical change. It is a self-propagatory electrochemical change traveling along the cell membrane. So it is traveling along the cell membrane of the conducting tissue. Okay, of the cell membrane of the conducting tissue and the muscle fibers of the heart. Okay. And the muscle fibers of the heart during its excitation. Apex beat. It is the lowermost and outermost point of the cardiac impulse and lies in the left fifth intercostal space. Left fifth. It is an take there's a billion times. A C A was atrial systole. X was atrial relaxation. X dash X. Then C was cuspid, like cuspid overturning, cuspid bulging into the right atrium back. V was X dash was what is X dash? End of ventricular contraction. Correct. V was vena cava filling back. Vena cava filling and Y I guess start of atrial emptying. Okay, the passive emptying. It done. Nice, 7 minutes. उसमें also I was talking also थोड़ा, so not bad. Show the relative anatomical position of valves of the heart and their respective areas of auscultation in the diagram. This is the sternal angle, this is the second rib, this is the suprasternal notch, this is the second intercostal space, this is the fourth intercostal space, fifth intercostal space, fourth intercostal space, and the fifth intercostal space. Okay, done. Nice, that was pretty quick. And then almost 1 hour I finished the entire CVS respiration. That was very productive. And now I think I will take a break. It's important to take breaks also. You have continuously be sitting for 1 hour. The first 10 minutes I was just making the tomorrow's meat and getting things ready. So I've been sitting continuously for 1 hour. Now it's important to wind down. Imagine I stayed up yesterday 17. I sat for 17 hours. I slept late a bit. I shouldn't have, but I slept late and I slept only like 5 hours or something. I got up at 4:30, but still we are at peak productivity and we're gonna keep it up because you have to maintain that productivity no matter how hard you work the previous day. That shouldn't carry on. I shouldn't be get tired, but I shouldn't burn out also. To avoid burnout I have to take breaks. So now I'll lie down for a bit for like maybe 5 minutes and I'll come back by when the time reaches 120. So when it's 5:50 I'll be back. So till then you also take a break. You've also been studying for 1 hour and we'll meet again at 120. When this reaches 120 at 5:50, you and I'll take a power nap 5 minutes. Okay, nice. So it's good morning. We have to now. I have to do jugular venous pressure. That is one concept I had not understood. So I'll work on that. कितने बजे 6 बजे ना 7:30 then I'll just pack everything, organize everything, and कल का एक दो बैकलॉग I'll cover जो बचा था. Yes, that makes sense. And I'll plan my day for today. Planning yesterday I wasn't able to plan. I didn't have time. So making a plan is a must. Very important. I'll see jugular venous pressure video.
Straight measurement of JVP. As you see in this case, we will go by some steps. Step 1, make the patient 45-degree angle. Neck should be relaxed and the head should be slightly turned to the left side. And here you can see the landmarks. That is, you can see the pulsations of the external jugular vein. This is the external jugular vein pulsations as it is crossing the sternum to the mastoid side. And here you can see the landmarks. That is, you can see the pulsations of the external jugular vein. This is the external jugular vein pulsations as it is crossing the sternum to the mastoid.
I think I'll write this down in my notebook because next time I don't want to have to watch the video. So to make one source LMR, I've added all points from all sources into this one book. So I had everything here. Here we can highlight. That's why it's so blank. Otherwise, you'll never see my book like this. It's a journal. That's why. But otherwise, all my books are very colorful. So one is you keep the patient at 45 degrees, neck muscles relaxed. 45-degree neck muscle relaxed and point turning to the left.
In this case, we will go by some steps. Step 1 is make the patient 45-degree angle. Neck should be relaxed and the head should be slightly turned to the left side. And here you can see the landmarks. That is, you can see the pulsations of the external jugular vein. This is the external jugular vein pulsations as it is crossing the sternocleidomastoid muscle, going towards the angle of mandible, and here it is the you can see the pulsations of the internal jugular vein. You can see here the pulsations of internal jugular vein, the mastoid muscle going towards the angle of mandible, and here it is the you can see the pulsations of the internal jugular vein. You can see here the pulsations of internal jugular vein. This is external jugular vein. This is the internal jugular vein pulsations. And if you see the internal jugular
Internal vein pulsations are more medial to the lateral. So let's just have the next break. I'll be taking the next break at 7 p.m. next break, and usme you can ask your doubts at 7. So if you can 7 p.m. do come and ask your doubts. I'll answer for like 5-10 minutes, and I'll have to pack. But 7 p.m. will be our next break, and then I'll answer your doubts also. Usme. So you can come back at 7. I'll pin this message too. How do you pin? Okay. Anyways, press on it. Yeah. Fast. Leave it. Yeah. ठीक है नहीं हो रहा है. Okay.
vein pulsations upper limit is this. This is the upper mark. So step 1 over. Now step 2 we have identified the external jugular, internal jugular. Sometimes internal jugular venous pulsations are very difficult to visualize because they're deep seated in facial planes. Sometimes but the external jugular vein pulsations are easily seen. In those circumstances, you can go for external jugular vein pulsations, as there was an earlier video in the clinical snippet. In this case, we are able to identify the internal jugular vein pulsations here. So, if you see, this is the upper limit of internal jugular vein pulsations. So, step 3 we start. Step 3 we have to start identifying the angle of Louis sternal angle. This is a sternal angle. So step 3 we start. Step 3 we have to start identifying the angle of Louis sternal angle. This is a sternal angle. Keep the scale here, and you have already identified the internal jugular vein pulsations. Okay. Angle. This is a sternal angle. Keep the scale here.
This.
And you have already identified the internal jugular pulsations.
Okay.
Okay. So this is the upper limit of internal jugular vein pulsations, and making the parallel, the second scale should be parallel to the ground. This is the measurement.
So from the keep it parallel to the ground.
This is the measurement. So this is around 3.5 centimeter. If we add 5 to 3.5 centimeter, it becomes 8.5 centimeter. So JEP is raised. So this is around 3. This is the measurement.
Measured and sleeping position.
So this is around 3.5 centimeter. If we add 5 to 3.5 centimeter, it becomes 8.5 centimeter. So JEP is raised.
And not PM.
So this is around 3.5 centimeter. If we add 5 to 3.5 centimeter, it becomes 8.5 centimeter. So JEP is raised. This is how we measure the JEP. this is the measurement. So this is around 3.5 centimeter. If we add 5 to 3.5 centimeter, it becomes 8.5 centimeter. So JEP is raised.
यहाँ से when you are bending down कितना कहाँ तक पहुँच रहा है and you keep this parallel to the ground. Okay.
So this is around 3.5 centimeter. If we add 5 to 3.5 centimeter, it becomes 8.5 centimeter. So JEP is raised. This is how we measure the JEP.
I'll make my plan for the day. Let's finish lots of stuff. Currently, I think we have a few CVS left. Yeah, good job, Aditi. And I'm in first year MBBS. Now, do you consume drop? 26? No. What happens? It stays. So this is my schedule for today in college. So I have a calculation, CPS, local blood flow, biochem, and renal. So after I should be able to revise these things today, tomorrow. Should be able to revise this in within today and tomorrow. So today I have 9 to 10 coronary circulation. Okay, that's there for our exam also, coronary. And CVS, everything is CVS only currently. Everywhere only I'm doing CVS. Local blood flow. GBS and RAS. Okay. So today, let's revise what they're going to teach. First time in my life, I'm actually revising what the teachers. I don't know what else to do. This actually, then I actually pay attention because otherwise I end up sleeping sometime. This the teaching is great, but I'm not able to understand sometimes because of my lack of attention probably. But it's if I read about it and go, I feel thoda sa I'll have some orientation what is being taught. So now I'm going to read first time. That's so cool. I feel this is also a milestone that first time I'm reading before a lecture. Okay. So by reading, I don't think I like study it. Let's go over at least the subtopics. Actually, I'll read in quick mode. So we can do it. Where's coronary circulation? It's a small topic. Done. So reading is worth it. And this morning time is the best time to do that. So even you all should do this if you're in coaching also. Thoda if you have orientation about a topic now. Actually, it's difficult for physics and all, but bio वगैरह if you have in your coaching, you can definitely read and go. It definitely helps. Use the morning time for that. You the best time now. It's before anything starts before like anything can start 4:30 is the best time and you can't 4:30 will never overlap with any time. So let's go. We're starting coronary circulation. and I'm gonna time each page and make sure I finish before 10 minutes because this takes a while. Of course, it's just a basic reading upper se, but I'm just trying to get an idea of what the topic is. Need all my highlighters and okay. Now, angina pectoris is a symptom of myocardial ischemia in which there is a chest pain usually brought about by exertion and often referred to on the inner part of the left arm. Autoregulation of blood flow. The ability to maintain near constant flow despite changes in blood pressure with a specified pressure range apart from coronary circulation, as seen in renal and cerebral circulation. So coronary में नहीं दिखता. Coronary collateral circulation, the circulation of blood through secondary channels when the primary artery is occluded. So coronary is a secondary channel in the primary artery is occluded. Myocardial infarction is a reduction in blood flow to a part of the myocardium resulting in cell death, that is necrosis. It's reduction to a part of the myocardium causing necrosis, that is called myocardial infarction. Okay, there's necrosis involved. Myocardial ischemia. So infarction is blood flow कम हुआ, ischemia is insufficient blood flow to the myocardium resulting in chest pain. Angina pectoris. So ischemia में you have chest pain. Infarction में also होगा, but ठीक है. This is a very basic definition. About 1/3 of all deaths in industrialized countries of Western world result from coronary artery disease. However, this has become increasingly problem in developing countries as lifespans increase and lifestyle behaviors change. For this reason, understanding normal and condition, physiology and anatomy of coronary blood supply shows the heart and the coronary blood supply. Note that the coronary arteries lie on the surface of the heart, and the smaller arteries, the coronary. Note that the main coronary arteries lie on the surface of the heart, and the smaller arteries then penetrate from main coronary arteries lie on the surface, correct? And the smaller arteries then penetrate from the surface into the cardiac muscle mass. Smaller arteries are penetrating from the surface into the. Okay, I just read it very thoroughly, so I'm done with it also. Smaller arteries are penetrating from the surface into the muscle mass. ठीक है. मेन कोरोनरी आर्टरी किधर है? सरफेस पे है. स्मॉलर आर्टरीज किधर है? सरफेस से. दे आर पेनिट्रेटिंग इनटू स्मॉलर मसल मास. It is almost entirely through these arteries that the heart receives nutritive blood supply. Only the inner 1 by 10 millimeters of the endocardial surface can obtain significant nutrition directly from blood inside the cardiac chambers. Only 1/10 of the endocardial surface can obtain the blood directly from the cardiac chamber, so this source of nutrition is minuscule. The left coronary artery supplies mainly the anterior and left lateral positions of the left ventricle. Left coronary artery, I have learned in anatomy, but I have not done it properly. Left coronary artery, mainly the anterior and the left lateral. Okay, anterior and left lateral position. Correct. Anterior and left lateral position of the left ventricle. Left coronary artery supplies the anterior and the left lateral position of the left ventricle, whereas the right coronary artery supplies most of the right ventricle. Right coronary artery supplies most of the right ventricle as well as the posterior part of the left ventricle. So right coronary artery supplies the right ventricle and the posterior part of the left ventricle. Most of the coronary venous blood flow from the left ventricular muscle returns to the right atrium of the heart by way of coronary sinus. Coronary venous blood flow returns from left ventricular muscle. Left ventricular muscle. Left ventricle, ठीक है, is returning to the right atrium by way of coronary sinus, which is about 75%, which is about 75% of total coronary artery blood flow. So it mainly drains into coronary sinus. On the other hand, most of the coronary venous blood flow from the right ventricular muscle mass returns through small anterior cardiac veins. Most of the coronary venous blood flow from right ventricular muscle. Coronary venous blood flow from right ventricular muscle mass returns through small anterior cardiac veins. ठीक है, राइट वेंट्रिकल से जो भी venous blood that returns from anterior small cardiac veins that flow directly into right atrium. So right side goes into anterior small cardiac veins directly right atrium में जाते हैं from right side. From left side they first go into the left coronary. They go into the left ventricular muscle goes directly to right atrium through the coronary sinus. So left ventricle coronary sinus, right ventricle through the small anterior cardiac veins that drain into the right atrium. Not by way of coronary sinus. A very small amount of coronary venous blood also flows back into the heart through very minute Thebesian veins, which empty directly into all chambers of the heart. Thebesian veins empty into all chambers of the heart. Thick Thebesian veins empty into all chambers of the heart. Normal coronary blood flow averages about 5% of cardiac output. Okay, the normal coronary blood flow nesting human being averages 70 ml per minute per 100 gram of heart weight. 70 ml per minute per 100 gram of heart weight, or about 225 ml per minute, which is 4 to 5% of the cardiac output. Okay, so 5% of cardiac output is the coronary circulation. 70 ml per minute per 100 gram of heart. Salient features of coronary circulation are total of 4 to 5% of cardiac output, that is 225 ml per minute. 225 ml per minute. उसका 20 times करो, हाँ 5 liters, ठीक. High capillary density. Coronary circulation has a high capillary density. Coronary circulation has high capillary density. Coronary circulation has high capillary density. Coronary circulation has high capillary density. Distribution of blood flow in the right and left coronary arteries. Coronary circulation has high capillary density. Distribution of blood flow in the right and left coronary artery varies. Some individuals are left coronary artery dominant, others are right coronary artery dominant. Right dominance, left dominance. Now I have to revise all this. Extraction of oxygen from coronary arteries at rest is high. Okay. Oxygen extraction is high. Blood flow is closely coupled to cardiac metabolism. Coronary circulation shows auto-regulation of blood flow. It is phasic. More during diastole and minimal during systole. Makes sense. It is okay. Because systole mein you want to probably pump it more into the lungs and the rest of the body. So we can number like that. So then it's diverted towards that. So it's decreasing to in the coronary circulation. So coronary increases during systole. So it's phasic. Phasic nature is more pronounced in the left ventricle. Correct. That's to pump to more extent. Correct. So phasic nature of coronary blood flow is seen more in left ventricle. Makes sense. The coronary blood vessels are end arteries but have functional anastomosic vessels called colaterals. Coronary blood vessels are end arteries but have functional anastomotic vessels called collaterals. During strenuous exercise, the heart in young adults increases its cardiac output fourfold to sevenfold and pumps its blood against a higher than normal arterial pressure. Consequently, the work output of the heart under severe conditions may increase 6 to 9-fold. At the same time, the coronary blood flow increases threefold to supply the extra nutrients of the heart. Cardiac muscle compression during phasic changes cause changes in coronary blood flow during session. The figure shows the changes in the blood flow through the nutrient capillaries of the left ventricular coronary system. It shows the changes in the blood flow in the nutrient capillaries of the left ventricular coronary system in milliliters per minute in the human heart during systole and diastole. As extrapolated from studies in experimental animals. Note from this diagram that the coronary capillary blood flow in left कौन सा diagram है? Coronary capillary blood flow in the left muscle. Coronary capillary blood flow in the ventricular muscle falls to a low during systole. Okay, we finished. Took a bit of time, not ideal. 10 minutes, like I said, but can do better. Can do better. I mean, each page is pretty big, but that's okay. Lot of action-packed information. Next, we have the reason for this phenomena is the strong compression. Note from the diagram that the coronary capillary blood flow in the left ventricle falls to a low during systole. Okay, okay. The reason for this phenomenon is the strong compression of the intramuscular blood vessels by the left ventricular muscle mass. Oh, that's the reason. The strong compression of the intramuscular blood vessels by left ventricular muscle mass. Strong compression. During diastole, the cardiac muscle relaxes and no longer obstructs the blood from the left ventricular muscle capillary, so the blood flows rapidly in all of diastole. Blood flow through the coronary capillaries of the right ventricle also undergoes physical changes during the cardiac cycle because the force of conduction of the right ventricular muscle is far less than the left ventricular muscle. The inverse phasic changes are only partial and in contrast to those of the left ventricular muscle. Epicardial veins, subendocardial coronary blood flow, effect of intramyocardial pressure. Epicardial versus subendocardial coronary blood flow, effect of intramyocardial pressure. Epicardial versus subendocardial. So you're doing epicardial versus subendocardial. ठीक है. Figure 46. So this is phasic flow during the coronary capillaries from the human left ventricle and systole. So systole में कम हो रहा है और diastole में बढ़ रहा है. ठीक है. जैसे राइट pulmonary artery ठीक है. Left circumflex branch, left anterior descending branch (LAD). Left circumflex. Left coronary artery becomes a left circumflex branch as well as a left anterior descending artery. Left anterior descending artery and the left circulating branch. Left anterior circulating, left circumflex and left anterior descending branch and left circumflex branch. Okay. During the diastole, the cardiac muscle relaxes. During diastole, the cardiac muscle during diastole, the cardiac muscle relaxes and no longer obstructs the blood flow through the left ventricular muscle capillaries. Systole and diastole. So diastole में cardiac muscle relaxes and no longer ठीक है. Demonstrate a special arrangement of coronary vessels at different depths in the heart muscle, showing on the outer surface epicardial coronary arteries that supply most of the muscle. You're showing on the outer surface epicardial coronary arteries that supply most of the muscle. On the outer surface, epicardial coronary arteries that supply most of the epicardial coronary arteries. Okay, what am I doing? Why am I spending so much time on this? Epicardial coronary arteries that supply most of the muscle. Smaller intramuscular arteries derived from the epicardial arteries. There are smaller intramuscular arteries derived from the epicardial arteries. Penetrate the muscle supplying the needed nutrients. They're penetrating the muscle supplying the needed nutrients. Lying immediately beneath the endocardium is a plexus of subendocardial arteries. Beneath the endocardium, you have subendocardial arteries. Beneath the endocardium, you have subendocardial arteries and the smaller intramuscular arteries from the epicardial arteries. And you have also subendocardial arterial plexus beneath the endocardium. Epicardial, intramuscular, and subendocardial coronary vasculature. During systole, the blood flow through the subendocardial plexus of the left ventricle. Blood flow through the subendocardial plexus of left ventricle. The intramuscular coronary vessels are compressed greatly when and tends to be reduced. Okay, extravascular vessels subendocardial plexus normally compensate for this reduction. Extravascular of the subendocardial plexus normally compensate for this reduction. Cardiac plexus normally subendocardial plexus. Hmm. Faster, faster. My one problem is that, like, when I get stuck on something, then I waste too much time on it, and then I get demotivated that I'm wasting too much time, and then I waste more time. That's one thing I want to break. Half the time, that thing which I'm stuck over is not even that important. So, the extra vessels in the subendocardial plexus normally compensate for this reduction. Later in the chapter, we'll explain the difference between the blood flow in the epicardial and subendocardial arteries play an important role. So the subendocardial arteries compensate for the epicardial arteries. ठीक है. Control of coronary blood flow, local muscle metabolism. Local muscle metabolism is the primary controller of the coronary flow. Local muscle metabolism. Blood flow through the coronary system is regulated mostly by local arteriolar vasodilation, locate response to nutritional needs of the cardiac muscle. Arteriolar vasodilation. There is an arteriolar vasodilation in response to nutritional needs of cardiac muscle. Arteriolar vasodilation. Okay, so fast. That is where whenever the vigor of cardiac contraction is increased, the rate of coronary blood flow also increases. The local regulation of coronary blood flow similar to that occurring in many tissues of the body, especially in the skeletal muscles. Oxygen demand is a major factor in the local coronary blood flow regulation. The blood flow in the coronary supply usually is regulated almost exactly proportional to the need of cardiac musculature. Blood flow is for oxygen. Normally, about 70% of oxygen in the coronary artery blood is removed as the blood flows to the heart muscle. 70% of oxygen in the arterial blood, coronary artery blood is removed as the heart flows to the heart. Blood flows. 70% of oxygen is removed when it flows to the heart. It was 70 minutes. I was distracted from 20 minutes like break. It happens. You have to put a break to the break. That is the most important thing. I set very strict deadlines for myself. Now I've started that. You my break overshoots, then that mood goes. That then you feel like, oh shit, I wasted 20 minutes. And then you feel even more less energized to do it. But if you're in a continuous thing, "Ki, I've been so productive for 5 hours, I'll just keep going," then you get a more reason to be more productive. Normally, 70% of the oxygen in the coronary artery is removed. Only 70% of the oxygen in coronary artery blood is removed as the blood flows through the heart muscle because not much oxygen is left. Little additional oxygen can be supplied to the heart musculature unless the coronary blood flow increases. Fortunately, the coronary blood flow increases almost in direct proportion to any additional metabolic consumption of oxygen by the heart. The exact means by which increased oxygen consumption causes coronary dilation has not been determined. A substance with great vasodilator property is adenosine. Adenosine is a vasodilator. I did not know. I knew this. I can't. Yesterday only I read this. Adenosine is a vasodilator. Adenosine is a vasodilator. in the presence of very low concentration of oxygen in the, oh, nicely finished in 9 minutes 53 seconds. Improvement from 10 minutes, but I think I was wasted a bit time in the middle, but not bad. As long as we're maintaining 10 minutes, not bad. In the presence of very low concentration of oxygen in the muscle cells, very low concentration, back focus. In the low concentration of oxygen in muscle, a large proportion of cells ATP degrades to AMP. Okay, अगर ऑक्सीजन कम होगा तो ATP is converted to AMP for energy, I guess. And ATP degrades to AMP. Small portions of this substance are then further degraded to release adenosine into the tissue. So small portions are further degraded and release adenosine into the tissue fluid of the heart muscle. They release adenosine into tissue fluid of heart muscle. Okay. With a resultant increase in local coronary blood flow because of vasodilation. Oh, the vasodilation will decrease the resistance and increase the flow to that area. Makes sense. So what is happening is ATP is getting converted to AMP because of oxygen is less. Now that ATP becomes AMP, that AMP is converted to adenosine. Adenosine is a vasodilator, increases the blood vessel diameter, decreases the resistance, increases the blood flow, more oxygen. What a cool mechanism. After the adenosine causes vasodilation, much of it is absorbed into the cardiac cells and can be reused for production of ATP. That's so smart. Other vasodilators include adenosine phosphate compounds, potassium ions, hydrogen ions, CO2, prostaglandins, nitric oxide. Vasodilators are adenosine phosphate. Potassium is a vasodilator. Hydrogen ions, CO2, prostaglandins, and nitric oxide. Vasodilators include nitric oxide, nitric oxide, H plus, CO2, K plus, and adenosine phosphates. Abhi I'll study probably till 7:30. Till I finish this. I have, 1, 10, 20, 10, 20, 30, 35, 40, almost 40 minutes, so minimum. 7:20 I'll finish. Chal. 7:20 we'll stop. So till then I have to finish. Let's go. The mechanism of coronary vasodilation during increased cardiac activity. The mechanism of coronary vasodilation during increased cardiac activity are not fully explained by adenosine. Okay. Pharmacological agents that block or partially block the vasodilator effect of adenosine do not prevent coronary vasodilation caused by increased heart muscle activity. Pharmacological that block or partially block the vasodilator effects of adenosine do not prevent coronary vasodilation. Oh, they're giving the proof. Damn. So adenosine doesn't have much effect because when pharmacological agents that are blocking the vasodilator effect of adenosine are given, they still are not able to prevent the vasodilation seen during increased cardiac output. That is so cool. Okay. Nervous control of coronary blood flow. Nervous control. The simulation of ANS to the heart can affect coronary blood flow directly. The direct effects result from action of nerve transfer substances, acetylcholine from the vagus nerves and norepinephrine from the sympathetic nerves. So vagus is always secreting acetylcholine and norepinephrine is being secreted from the sympathetic nerves. Oh, okay. Sympathetic nerves will secrete norepinephrine. But acetylcholine is being secreted by apna vagus. The indirect effects result from secondary changes in coronary blood flow caused by increase or decrease of. So indirect effects result from secondary changes in coronary blood flow caused by increased or decreased activity of the heart. So there's an indirect effect that is resulting from the secondary changes in the coronary blood flow. or by increase the indirect effects are mostly opposite to the direct, so a far more important role than normal condition of coronary blood flow. Thus, the sympathetic stimulation releases norepinephrine from the sympathetic nerve, norepinephrine and epinephrine from the adrenal medulla increases both the heart rate and heart contractility and increases the rate of metabolism of the heart. In turn, the increased metabolism of the heart sets off local blood flow regulatory mechanisms for dilating the coronary vessels, and the blood flow increases approximately in proportion to the metabolism of the heart. Hmm. In contrast, vagal stimulation with the release of acetylcholine. Vagal stimulation with the release of acetylcholine slows the heart and has a slight depressive effect on the heart. In contrast, vagal stimulation with the release of acetylcholine slows the heart and has a slight depressive effect. Vagal stimulation with the release of acetylcholine constrict the coronary arteries. Direct effects of nervous stimuli on the direct coronary vasculature. Distribution of asymptotic vagal fibers to the ventricular coronary system is not very great. However, the acetylcholine released by parasympathetic has a direct effect to dilate the coronary arteries. Parasympathetic to the more extensive sympathetic innervation of coronary vessels occurs. Besides sympathetic transmitter substances, norepinephrine and epinephrine. Sympathetic transmitter substances. The constrictor receptors are called alpha and the dilator receptors are called beta. So for epinephrine and norepinephrine, alpha causes constriction. Alpha constriction, and beta causes dilation. Beta D glucose. So beta is dilator, beta D. Beta is beta D glucose, so beta D. So beta dilation. So alpha is for constriction, beta for dilation, and this is epinephrine or epinephrine for beta. Okay. Beta receptor. Cardiac alpha and intramuscular beta. Therefore, sympathetic stimulation at least theoretically cause slight overall coronary constriction or dilation. Sympathetic stimulation can cause at least slight overall constriction or dilation. It's already 8 minutes. I'm only halfway done. No, what am I doing? Okay. And in it cause slight overall coronary constriction or dilation, but usually constriction. In some people, the alpha vasoconstrictors seem to be disproportionately severe, and these people can have vasotic myocardial ischemia during periods of excessive sympathetic drive, with resultant anginal pain. Excess sympathetic drive means you have resultant anginal pain. These people have vasospastic myocardial ischemia. Vasospastic. No constriction. They'll have vasospastic myocardial ischemia. It's already been 10 minutes. I'm slacking. Metabolic factors such as myocardial oxygen consumption are major controllers of myocardial blood flow. Myocardial oxygen consumption are major controllers of the coronary blood flow. Okay. Another direct effects of nervous stimulation reduce the coronary blood flow. Metabolic control of the coronary blood flow usually overrides the direct coronary nervous within seconds. Okay. My highlighter is also over there. Second new highlight. Special features of the cardiac muscle metabolism. The basic principles of cellular special features of the cardiac muscle metabolism. Basic principle. Basic principles of cellular metabolism apply to cardiac muscle the same as for other tissues. The basic principles for cellular metabolism apply to cardiac muscle apply the same as in what? Under resting condition, cardiac muscle usually consumes fatty acids instead of carbohydrate. To supply most of its energy, 70% is derived from fatty acids. So 70% of the energy of the cardiac muscle during normal production is due to fatty acids. However, it is also true of other tissues under anaerobic or also true of other tissues other than anaerobic or ischemic condition. Cardiac metabolism must follow anaerobic glycolysis mechanisms. Storage energy. However, glycolysis consumes large amounts of blood glucose and at the same time forms large amount of lactic acid in the cardiac tissue, which slowly the cause of cardiac pain in cardiac ischemia, as discussed later. As true in the other tissues, more than 95% of the metabolic energy liberated from foods is used to form ATP. As is true with in other tissues, more than 95% of the metabolic energy liberated from foods is used to form ATP in the mitochondria. This ATP in turn acts as a conveyor of energy for cardiac muscle contraction, and other side functions. The big organization by the ATP degrades phosphoadenosine diphosphate. Adenosine monophosphate and adenosine, because of the cardiac muscle cell membrane is slightly permeable to adenosine, the agent can diffuse into the muscle cells. The agent can diffuse from the muscle cells into the circulating membrane. Very slow. Stereochromal tyrosine material diffuse from the muscle cells into the circulating blood. The released adenosine is believed to be a substance that causes dilation of coronary arterioles during coronary hypoxia. Dilation of coronary arterioles during coronary hypoxia. A loss of adenosine has a serious cellular consequence. Within as little as a loss of adenosine has a serious cellular consequence within as little as 30 minutes of So it has a serious cellular consequence. 30% of coronary stream and the cause of the myocardial infarction, one half of the adenosine base will be lost from the affected cardiac muscle cell. For the most loss and replaced by 2% for necessary for the formation of the system. The question will be too late. And so So adenine deficiency is one of the major causes of death. In myocardial ischemia. Myocardial ischemia. This is too much. Ischemic heart disease. Ischemic heart disease. Ischemic heart disease. The cause of ischemic heart disease. A frequent cause of diminished coronary blood flow is atherosclerosis. People have genetic predisposition to atherosclerosis who are overweight. Oh, yeah. Can have a genetic predisposition. Nice. You're overweight, obese. So genetic predisposition to atherosclerosis, obese, sedentary lifestyle, or high blood pressure. So sedentary lifestyle, genetic predisposition to atherosclerosis, genetic predisposition, obesity, sedentary, high blood pressure, and damage to endothelial cells. High blood pressure, sedentary lifestyle, high blood pressure, sedentary lifestyle, mm, high blood pressure, sedentary lifestyle. ठीक है. Mm, damage to endothelial cells, large quantities of cholesterol gradually become deposited. Damage to the endothelial cells of coronary blood flow. Damage to endothelial cells of the coronary blood vessel. Endothelial cells. Endothelial cells. Large quantities of cholesterol gradually become deposited beneath the endothelium at many points in the arteries of the body. Large quantities of cholesterol gradually become deposited beneath the endothelium at many points. Large quantities of cholesterol become deposited beneath the endothelium. Beneath the endothelium. Okay. Large quantities of cholesterol at many points in the arteries throughout the body. Gradually, these areas of deposit are invaded by fibrous tissue. Deposited beneath the endothelium at many points throughout the body. Gradually, these areas of deposit are invaded by fibrous tissue. Gradually, these areas of fibrous tissue frequently become calcified. This atherosclerotic plaques that actually protrude into the vessel lumen can either block or partially block blood flow. Comedotic development of atherosclerotic plaques is the first few centimeters of the major coronary arteries. Acute coronary artery occlusion. Acute coronary artery occlusion. Acute coronary artery occlusion. Acute coronary artery occlusion most frequently occurs in a person. Acute coronary artery occlusion. Oh, this page took literally 20 minutes. I over took double the time. So not done, but it's okay. Next page we can cover up. Not cover up, but at least keep it under 10. Acute occlusion of a coronary artery most frequently occurs in a person who has underlying atherosclerotic coronary heart disease. So, can be acute occlusion of coronary arteries, acute in a person who has underlying atherosclerotic who has atherosclerotic heart disease, but never in a person with a normal coronary circulation. Acute occlusion most frequently occurs in a person who has underlying atherosclerotic coronary heart disease, but almost never in a person with normal coronary acute coronary artery occlusion. Life-saving value of collateral circulation heart. The degree of damage to the heart muscle caused either by slowly developing atherosclerotic constriction of the constricted arteries or by sudden occlusion is determined to a great extent by degree of collateral circulation that is already developed that is and open within minutes. In a normal heart, no large communication exists among the large coronary arteries. How many anastomosis do exist among the smaller arteries? 20 to 59. When a sudden occlusion occurs in the larger coronary arteries, small anastomosis begin to dilate within seconds. The blood flow through these minute collaterals is usually less than one half that is needed to keep alive most of the cardiac muscle that they now supply. The diameter of the collateral will not enlarge for more than next. As the collateral flow begins to increase, doubling by the second or third day and reaching normal or almost normal coronary blood flow within 1 month. Because of these developing coronary channels, many patients recover almost completely from various degrees of coronary occlusions. Now, myocardial infarction normally after acute. Yeah, I was just seeing. Yes, I'm first MBBS student. नहीं मैंने देखा था कल कितने व्यूज आए. It's 2,500 views almost on stream. That's really cool. I'm in first MBBS. Sure, yeah, actually, you're right. I should be focused. Immediately after an acute coronary occlusion, blood flow ceases in the coronary vessels beyond the occlusion. So, immediately after coronary occlusion, the blood flow will cease in the coronary vessels beyond the occlusion. Except for small amounts of collateral flow from surrounding vessels. The area of the muscle that has either zero flow or so little flow that it cannot sustain cardiac muscle function is said to be infarcted. So that occurs due to an occlusion, coronary artery occlusion. Overall process is called myocardial infarction. Soon after the onset of infarction, small amounts of collateral blood begin to seep into the infarcted area, which with combined with a progressive dilation of local blood vessels. With a combined dilation of local blood vessels causes the area to become overfilled with stagnant blood. So, with combined which combined with progressive dilation need to seep into the collateral blood is seeping into the infarcted area. Correct. Causes the area to become overfilled with stagnant blood. Simultaneously, the muscles fibers use last vestiges of oxygen in the blood, causing the hemoglobin to become totally deoxygenated. Therefore, the infarcted area takes a bluish brown hue, and the blood vessels that appear to be engorged despite lack of blood flow. Within almost few engorged, I guess means like swelled. Okay. Engorged within a few hours of almost no blood supply, the cardiac muscle cells die. Cardiac muscle requires 1.3 ml of oxygen per 100 gram of muscle tissue per minute to register ml normal resting left ventricle per minute. Therefore, even if 15 to 30% of normal resting for any blood flow, the muscle will not die in the central portion of the large infarct. However, when there is subendocardial infarction. So, thank you. Yes, I know. बहुत एग्जाम्स दिए मैंने. Subendocardial infarction. The subendocardial muscle frequently becomes infarcted even when there is no evidence of infarction. Subendocardial infarction. The subendocardial muscle frequently becomes infarcted even when there is no evidence of infarction. So no evidence of infarction in the outer surface portion. The reason for this is that the subendocardial muscle has higher oxygen consumption and extra difficulty. Subendocardial muscle has higher oxygen consumption, extra difficulty obtaining adequate blood flow. Extra difficulty obtaining adequate blood flow, higher oxygen consumption, and extra difficulty obtaining adequate blood flow. Extra difficulty obtaining adequate blood flow because the blood vessels in the subendocardium are intensely compressed by systolic compression of the heart. Thank you. 7 एग्जाम्स है क्या? I mean, I haven't counted. The reason for this subendocardial muscle has oxygen consumption, extra difficulty obtaining. But this is just the beginning. We have to keep working hard. There are exams every 2 weeks in my life. So I want to maintain that. That's because there's no point with previous success. I've moved on from it. I got that, move on. I can't keep lingering on that previous thing. Now I'll focus on the next exams. Next exam. My main exam is NEET PG, which is in 1500 days basically. That exam is the most important exam in my life, and that's the exam I'm most focused about. More at least university and college exams are fine, important, but not really. The main exam is that NEET exam. Okay, it's 7. Which is I better finish. Okay. The reason for this is that the subendocardial muscle has a higher oxygen consumption. Subendocardial muscle has a higher oxygen consumption and extra difficulty obtaining adequate blood flow because the blood vessels in the subendocardium are intensely compressed by systolic contraction of the heart. Endocardium. Muscles. Subendocardial muscles. Okay, subendocardial muscles. Nice. We got 103. Okay, nice. Analytics. I have to finish this page and the next page. Hmm. 660. Yeah, almost 2 weeks. We have like some like small exams, like some like 10-mark exams. That we have almost every 2 days. We have some like that doesn't it counts to final internal marks. Finally, the board marks matter, the MUHS, but college exams keep going on, and like major college exam midterms we have every like 1 or 2 months. Then main thank you so much. The main like we have exams every 3 months to 4 months. The first internal, then second internal, then prelims, then the final uni. And in between we have midterms, we have continuous class tests. So every 2 weeks to aram se. I'll show you my. I made a schedule. It has. I made a schedule for 3 months. Whatever exams I have seen. This is till April I've made. So I've planned much in advance. Ki what all I want to see. This is my February. These are just more of things like see now tomorrow. Today is what? Yesterday I had a holiday. Today I have 27. So I have CVS skill certification. Then at 29th को probably have a protein exam on biochem, like छोटा सा exam. There's a constantly we have exams. This is March. This is all the exams that we have. We have a radio living exam. We have a research exam. We have a CCT. We have an basically journal submissions, PSM visit. Then April again. April also. All whatever is highlighted is probably usually exams. So see how many exams. Exams or some skills or something. The number of exams that and this is a second internal exam. The very important exam for us. Good morning, Gaurav. Hello, Yash. I'll upload a video today for last 2 months. It'll have everything you need for last 2 months. I wanted to upload it yesterday, but I streamed 17 hours. I did not have time to edit. I tried editing in the middle, couldn't complete it. Right. Yes. The reason for that is subendocardial muscle has higher oxygen consumption. Subendocardial muscle has higher oxygen consumption and extra difficulty obtaining adequate blood flow. Because the blood vessels in the subendocardium are intensely compressed by the they are intensely compressed by the systolic contraction of the heart. And extremely compressed by the systolic contractions of the heart, right? Intensely compressed by the systolic contraction. ठीक है. Blood vessels in the subendocardium are extremely compressed by the systolic contraction of the heart. Therefore, any condition that compresses the blood flow to any area of the heart usually causes damage first in the subendocardial regions, and the damage then spreads towards the epicardium. So, subendocardium and then spreads to the epicardium. Subendocardium and then spreads towards the epicardium. Subendocardium and that spreads towards the epicardium. Right. Now, causes of death after acute coronary occlusion. Causes of death during acute coronary occlusion. Causes of death during acute coronary occlusion. The most common causes of death after acute myocardial infarction are decreased cardiac output. So, the most common causes of death are decreased cardiac output, damming of blood in the pulmonary vessels, and death resulting from pulmonary edema. Damming of vessels and pulmonary edema, fibrillation of the heart, and occasionally rupture of the heart. So, you have decreased cardiac output, you have pulmonary edema, cardiac output is decreased, pulmonary edema is caused, fibrillation of the heart is caused. Cardiac output, fibrillation, rupture of the heart. Okay. 7:17. Okay. I think I'll start packing. Not bad. Today's morning was great. Absolutely amazing. I'm so proud of all of you who joined. And I'm so happy that, it's really hard to wake up at 4:30. So props to you also. When I was in 11th, 12th, I definitely wasn't able to wake up at 4:30. So that's amazing that, even within a day, all I've been able to wake up at 4:30. And, there were total today, there were around recurring views around 100. So that's amazing. So many of you all joined, and we achieved so much in the morning. That was great. Thank you, Anaya. Thank you. Yes, see you, Yash. And I'll pack and then I'll stop the stream and maybe let it reach 3 hours. Like, why not? It just looks nice. Then I'll stop it at 3 hours. We'll continue to do productive stuff. Yes, have a good day. I'm thinking, should I stream in the evenings, but then will it be too excessive? I don't know. It'll be too much. I think I'll keep it every day 4:30. I don't want to overburden myself. And then I shouldn't clog the feed also. It should look nice, like day one, day two, day three, like that sequence of events. And then if I put like random things in the middle, I won't. It'll break the chain. So 1500 days every day I'll stream only 4:30. I think. Uske baad maybe I can stream in the evenings also. But evenings I'll avoid. Let's see. I mean, ultimately, productive work should be done. So I don't mind streaming in evenings also actually. As long as everyone's being productive, it's a win-win. Hey, we reached 140 now. Yes, thank you. 140. 138, nice. Now the stream yesterday got 2,400 views. I'm gonna pack for today and also plan schedule actually. So I planned till the lectures now. Let's see. So today I have four lectures. Should end by 4:30. I'm really lacking in biochem and physio is going well now. I'm happy with physio. Biochem is still lacking tons. So today after college, I will stay back and read what was taught in biochem. Right. So today maybe say college ends at it'll end at 4:30. Say okay. So 4:30 to 6. Hmm. Either I stay back in college. Yeah, I will. I'll stay back in college. Biochem, जो भी पढ़ाया, I will study it today. Study it, not even revise. Study it properly, and I'll make notes, proper notes in class. Revise those notes and study from the textbook whatever was taught today properly. Biochem, I have to keep up and cover backlogs. I have tons of backlogs, so I'll divide it over long periods. That's how you should also go with your backlogs. Any backlog, good morning, Ria. Any backlog that you have, take over time. You have to divide it over like 3 months. Now I have 6 months for NEET. So you have your NEET in 1 year. You have to divide it over 3 4 months. Then only the backlogs. You can't plan to do. We can't finish it in one month or 1 week or anything. It has to be like a sustained overtime, realistic schedule, right? So 4:30 to 6 I'll do biochem, then 6 to 7 physio, 6 to 7:30 physio. Then I'll continue with CVS and probably I haven't touched anatomy. I don't know what is even going on. I have a radio living, huh? I have to ask sir how to go about it also. How to study for that. Okay. I think night I'll give for it anatomy. I can't skip anatomy now. Tomorrow the nat. So my god, microanatomy of intestine, histology. 7:30 to 9:30 anatomy abdomen. There's so much to do, but there's just can't seem to finish. MBBS is just too vast. Well, it's okay. We'll try our best. So today I have to do all three. Good, that is ideal. Biochem भी करना है, physio भी करना है और anat भी करना है. And I'll have to I'll end the stream at around 3 hours. Exact. Until then, I'll have to keep a literally a list called things to take for college. So in the morning, I don't have to think about I'll have to take. Like things to take. It's just a list of things I have to. I don't mechanically. I don't have to think only one thing. Apron डालना है, power bank. Power bank is a must. I think I'll charge it. 56. Oh, iPad is also not that charged. I'll charge iPad. Journal. Okay, then 3 hours are done. Bye, guys. See you tomorrow, 4 a.m., 4:30 a.m. Thank you for joining and really good productive morning session today. I was waiting for it to complete 3 hours. So, bye.